on mute until after both of our speakers have spoken, and then we'll be unmuted. Ting is going to handle the stack, and we'll have plenty of discussion between the two speakers, discussion with everybody, and some other union members and other people have already asked to ask questions and say things about their union during the chat. So I guess everybody is muted except us right now. So I just want to welcome everybody and thank you for coming out, especially during this tumultuous week. We actually have a lot of good work to do as the legislative session begins this year, and it's needless to say an extraordinary year. I want to thank our two amazing speakers for giving their time today to be with us, and I also want to thank Ting for what he's handling right now and everything else that he handles 365 days per year. So, as we gear up, so to speak, to continue the fight for health justice and all kinds of justice, we're taking a really close look at what it takes to pass the New York Health Act. We want to provide guaranteed publicly funded healthcare to every single New Yorker, and we have areas of resistance, areas of questions, and I think most of you know that unions have been an issue. We have some very supportive unions, and we always, with all issues, work very closely with our brothers and sisters who are in organized labor, and we want to keep it that way. But there are some special considerations, and I think that's why we're wanting to start the year with looking at the issue of unions and the New York Health Act. I mean, we certainly all agree that if there ever was a time to throw away that connection between healthcare and employment, this is the time. So I'm going to introduce both of our speakers. Gowri is going to speak first, but I want to first read, in case some people haven't, the very impressive bios of both of you. So I'll read both bios now, put my glasses on once because it's printed small. And then Gowri's going to speak, and then John is going to speak, and then everybody unmute and plenty of open discussion. Okay. So that
suggestion, Julie, maybe you should skip my bio since everybody's probably looked at it online. Why waste time going over it?
Well, I don't know.
Okay.
I think
okay.
It's worth saying again. I'm not going to say it slowly with big drama, but I think you have an impressive bio. So here goes. So first speaker, Gowri Parameswaran, who happens to be a very, very close friend of mine and somebody I organized with for years. She's professor and chair of educational studies and leadership at the State University of New York at New Paltz, where she's also vice president for Union, which is the Union of University Professionals. She got her master's and PhD in cognitive and educational psychology from Rutgers. Gowri grew up in India, moved to the US as an adult, and she's gone back and forth between the two countries and conducted cross-cultural research centering on gender, socioeconomic status and culture, and the impact of those factors on children and adults' cognition at both USA and India. She's co-editor of an introductory text for women's studies, Women, Images, and Reality, published by McGraw-Hill, and she's published books and articles about inclusion in education. And in recent years, she's written theoretical articles around developmental psychology and how to teach about such topics as the privileging of the global North, global South. She's currently working on exploring the exploitative consequences of the history of research on parenting and psychology in the age of structural and reduced government services for families in poverty. Thank you for that work. And John O'Malley, whom I have heard of for years, and I'm just meeting sort of in person on Zoom for the first time tonight. We really appreciate your speaking also. You're kind of known as the union guy who can answer a lot of different policy questions. So John O'Malley is the legislative coordinator for the Communication Workers of America, Local 1180 in New York City, representing public workers, hospital workers, and nonprofit workers. Prior to that, he served as the legislative and political coordinator for CWA Local 1120 in Poughkeepsie, which is part of that same area that Gowri is from and where I had been. That local was representing Verizon, landline, and AT&T wireless workers, several colleges, libraries, museums, and other public and private sector groups. Besides lobbying and organizing members around important legislation, John acts as liaison to many coalitions, including the AFL-CIO, Working Families Party, NIPAN, and New York PEC, which I didn't know what it was, so I Googled it so I could say, and if it's what I think it is, it's the Public Employee Conference, is that correct? Okay, and he's a certified trainer on the subject of runaway inequality and has trained other trainers in political intensive campaigns, participates in coalitions promoting gender and racial equality amongst workers, the funding of public hospitals in New York State, and statewide healthcare coalition of the CWA. He has acted as lead organizer for CWA's efforts to elect Bernie Sanders in 2016, yay, Bernie Sanders, through primaries in New Hampshire and Massachusetts, and also trained several new union activists to run political campaigns for Senator Todd Kaminsky. And he helped organize the petition drive for Bernie in the 18th Congressional District of New York. So very impressive also, thank you. All right, so, once again, if you're new to our email list and would like to be on it, just give us your name and email in the chat. Everybody is going to remain muted until both speakers have spoken, and then ask all the questions that you want. And then at the end, I think Ting has some action items in mind for us. So we will begin with hearing from Gowri.
So in my research, I've always believed that history tells us a lot about where we are now and the structures that we are working with. And I think someone else earlier suggested, why can't we just sort it out? And I think part of it lies in the history of the connections between the union movement and healthcare. Progressives all agree that we need a universal framework for availing of medical care, but few of us are willing to have a dialogue within our unions that will lead anywhere. The roots of where we are today lies in the history of labor and its relationship to employment and healthcare structures. Labor has played an outsized role in shaping healthcare policy in this country. Early push for healthcare availability formed the basic foundations of how we get healthcare today. The early success of workers in getting healthcare made labor withdraw from the struggle to define what health means and who is eligible, and handed it over to professionals, hospital administrators, and lobbyists. A lot of the structures that we see today is the result of the framework after the move to industrialization, where capitalists and workers had conflicting positions on how to manage a population dependent on wages and the precariousness of health in these industries. In the 1930s, as workers grew more radical in their organizing and demands, industrialists wanted to remove one of the most contentious negotiations, namely healthcare. They established hospitals affiliated with workplaces. In addition, Blue Cross became an NGO nonprofit that workers could sign on to. Initially, most insurance would only cover workplace accidents, but it became apparent that many health issues were indirectly a consequence of occupational issues, but it was hard to draw direct connections. Both doctors and policymakers were also trying to reframe questions about health and the different groups, the medical interest groups, the hospital administrators, pharmaceutical companies, insurance industries, and they were all in the contested territory to look out for their own interests. The American Medical Association consistently opposed universal health care, while employers did not want to be responsible for health issues arising from employment. After the Depression, with the rise of the more left-wing CIO, the call for national health care became louder. While labor and management fought over competing notions of disease and corporate responsibility, hospital administrators and their trustees battled a deep financial crisis as the Depression forced larger and larger numbers of impoverished clients into their general wards and emergency rooms. Unable to extract money from their clientele, many institutions faced the prospect of either shutting services or restricting admittance. Also, with union funds depleted, there was a search for external intervention. The current system we have really took shape after World War II with the American Medical Association kind of using the Red Scare to dissuade the public from supporting a universal system. At the same time, corporations began using healthcare as a way to subdue union power and bargaining. In an attempt to stop runaway inflation, the government froze wages. But in order to appease the population, the Internal Revenue Service ruled that fringe benefits would not be considered income and therefore were not subject to wage freeze. In addition, the government reimbursed war industries on a cost plus basis, which means total costs plus a set percentage for profit. This meant that a company that paid for its employees' hospital and medical insurance could now pass on the cost to the government and also could make a greater profit. This opened the door to private commercial insurance, leading eventually to the managed care system we have today. Employers controlling the overwhelming majority of plans, even though they were established through a collective bargaining process, the employer had ultimate control over how the plan was going to be administered. Earlier versions of the plan directly provided employees with health benefits, but as union power declined in the last 40 years, insurance companies no longer paid workers directly, but instead reimbursed professionals and institutions. Insurance industries became simple intermediaries, simply collecting the funds and passing along their cost to their clients. Blue Cross's traditional portrayal of itself as a partner in league with a benevolent community institution was now altered, and its partnership with hospitals was criticized by those who wanted insurance providers to play a more active regulatory role in holding down hospital rates. Instead, Blue Cross prayed out more to hospitals and charged higher premiums to its subscribers, maintaining its traditional stance as a passive collection agency. By the late 1950s, however, Blue Cross had emerged as the preeminent financial agent of America's hospital system. Healthcare became a narrowly defined aspect of workers' welfare benefits, and it was controlled by professionals largely ignorant of the broad social forces that affected workers' lives and well-being. I'm going to skip the next. And of course, Medicare and Medicaid was exactly, even though they were passed at the height of the civil rights movement and the federal anti-poverty activities, was perhaps the most dramatic federal attempt to make medical care a societal obligation. But even here, the historical link to health insurance and work helped shape the program. I mean, when I was looking at the single care, I mean, I wish I knew more about single care like Julie does, but even like the basic details, I mean, even if we'd switch to a single care system tomorrow, it would still be more privatized than the NHS of Britain or some of the other European countries which has national healthcare systems. So, I mean, the privatization of healthcare is so deeply rooted that it would take years to extricate ourselves from that. As the unionized workforce declines in numbers, as we have seen in recent years, and the percentage of the employed and as part-time workers are increasingly used as replacements for full-time union members, the number and percentage of those who are uninsured or underinsured will continue to rise. During the 1970s, as the crisis of healthcare slowly changed from one of access to one of costs, it became apparent that labor had given up more than it had gained. Both the creation of management-controlled HMOs, which were completely unaccountable to the labor movement, and the extraordinary rise in costs underscored the distance between a broad population of working people and the system that ostensibly offered them care. As the percentage of workers in unions decline and the number of part-time workers and self-employed workers who were denied health benefits increase, the fault lines that had appeared in the 1950s have become even wider today. In my own university, for instance, in the last 2 or 3 years, we've been going through some tumultuous times, more and more as, with budget constraints and less money coming in. One of the last contract that the UUP signed with the state, for instance, cut out healthcare benefits for a good portion of our part-time workers. They became more stringent about who was eligible for healthcare. Our pay to part-time adjuncts is so minimal that the only reason they even come to work as like teaching these courses is to get the healthcare benefits that come along with it. It's an oppressive system, and clearly, if there was healthcare available to them outside of the workforce, they would be able to negotiate better deals for themselves in terms of pay. But yet, our union has significantly, even though they have given lip service to the single-payer healthcare structures proposed, they have really not pushed for it, and they are very reluctant to push for it. And so it's frustrating for us, those of us, I'm a chair in my department and I work with part-time adjuncts who are exploited, who work more than what they're being paid for, but the only reason they show up is because they need the healthcare for their families and their children and so on. So my hope is that, when single payer arrives, a lot more of our workers can negotiate better raises for themselves and other benefits that would allow them to have a better work, significantly better working conditions. And with that, I'll stop. And, I'm sure John has a lot more to offer. You look like an expert, so I can't wait to hear you.
All right. You ready for me?
I just want to say thank you, Gowri. And yes, John, we are absolutely ready for you.
All right. I'm going to be looking at my notes on my screen, so I won't be able to see all of you guys. So if you make funny faces at me or put something in the chat or something, I won't be able to see it until I'm done, okay? All right, so anyway, single payer as a concept. I mean, we've been talking about this for a long time, talking about all the glories of it, ad nauseum, really. No costs at point of purchase, no searching for providers to take my insurance, no throttling of care, no bankruptcies from medical problems, no loss of coverage when you switch jobs or go on strike, or if you attain the old age of 27. Not having to keep a terrible job and put up with abuse just to keep your coverage, as Gowri just was talking about. If you're fortunate enough to have a union, no more distracted bargaining over runaway costs, no more having to negotiate over what else to give up to keep your insurance, or what parts of the insurance to give up to keep something else. And these and more are all the potentially good things that are possible with single payer. So what's the problem? Why is there such resistance? Are there nefarious forces at work that just don't want us to have good things? The private industry controlling our democracy, the corporate Democrats have sold out the citizens, influential unions acting in self-interest. I got mine, so you go get yours. Some of these things may all be true. Some of them may be true. But even if we removed or overcame all these obstacles, is the current bill in our best interest? In other words, if we passed this bill, signed it, implemented it, would it be what we want, really? I know nothing's perfect, but what are the problems? What are the downsides? Who's going to suffer when other people benefit? Who's left out? Can it be enforced? Can it be funded? Will the predicted funding stream remain stable, or will it evolve into another runaway cost? Will those most heavily relied upon for funding find ways to avoid contributing? Will the newly created bureaucracy be successful or just a quicksand trap? Will someone try to privatize it, or even worse, public-private partner it? These are all things to scrutinize, really, as we consider this bill. And these are things that gave the last newly elected state senate and assembly pause. So perhaps we should examine them. Most of these issues require courage as much as strategy to overcome, but most of the groups, and I think this is the same, have an excess of courage to deal with this. So we don't have to worry too much about that. But we should take care not to overlook the strategy part. This is the true legislative process. It goes beyond our own desire and activism, and it calculates the actual costs and tries to avoid them, really. Grease the skid, so to speak, rather than force through them. So in my opinion, the path forward for the New York Health Act is not only to apply the political and the community pressure that's necessary, but also to do the research and understand the various stakeholders' objections, not just labor, and to amend the bill to address those. The result is not only going to satisfy those stakeholders, but it's also going to be a superior product and a better result for all of us. Of course, I can't speak for various other groups, including other labor groups, nor do I represent them. In fact, I can only speak about my own opinion as it relates to my understanding of public sector unions' interest. So anything I say isn't even CWA Local 1180's official position, nor that of labor in general. But I hope that some things that I have to say might be useful for this group. Here are some general objections that are not necessarily specific to labor, but that the objectors from labor also share in these interests. First of all, it says everyone would have coverage, but who's everyone? Now, at first, it was just residents. Then it changed to residents or employees. Then it was, well, full-time employees or part-time employees. What if you live what if you live across the border in New Jersey somewhere, but you work in New York? Okay, if you work 40 hours a week, then you and your family in New Jersey can get coverage. But what if you work 30 hours a week? And so they dealt with some of that stuff. They've been modifying it as time has gone by, and it changes as we go. There's different problems that I'm sure you can envision either way. Coverage will be free, but different amounts of free depending on who you are, where you work, if you don't work, if you're retired. Actually, we don't even know how much it'll cost yet. Some people, like the unemployed or the poorly compensated, would get better coverage at cheaper rates or even free. Others, like independent contractors, gig workers, and so forth, would have to pay much, much more to get coverage at all. And then other people, like municipal union members, would get the same coverage, maybe a variant of the coverage that they have now, but now they'd have to pay more for it than they pay presently. What about the employers? According to some preliminary estimates, some employers, such as large companies of 50 or more, would save money by paying the payroll tax instead of the current premiums. It's estimates, of course. While other employers, typically the small ones, who do not currently pay any premiums, would have to begin paying. Will we give them a gradually implemented liability? Perhaps a tax break to offset those costs? Will they have to start paying immediately? Will we develop a new system of giving out companies pilot programs on their New York Health payroll taxes if they bring in businesses or hire new employees? How are these issues going to affect the already devastated small business community in this state? Will the extra costs drive even more out of business? Or how will such tax breaks affect other services that could be starved? There's thousands of people that work in the healthcare industry, not just for the insurance companies, but also for doctors' offices, medical billing, ombudsmanship, union benefit departments, even the state. So what's going to happen to them? The New York bill suggests a retraining system that seems pretty loosely organized, and it includes the possibility that a union could operate as a care coordination team. We haven't really figured all that out. I know myself and Ting and some other folks have been looking into that, but we haven't really figured it out yet. How does all that stuff work specifically? Those are kind of some general objections. But here's some specific ones for labor unions like mine. They may be common to other unions, by the way, but maybe not. I mean, there's other kinds of unions that have objections too, Taft-Hartley unions and other stuff like that. Number one, the biggest thing is it just seems too good to be true to a lot of union leaders. What we're talking about is better coverage that covers everyone who has coverage now, plus everyone who doesn't have coverage now, from cradle to grave, including long-term care, and it's going to be cheaper than it was before. And the quality and the quantity of care is going to be better. Well, many of us have spent many years costing out benefit packages at the bargaining table within the current system, and it seems impossible. For New York City workers, even non-union workers, the city charter requires that the benefits are provided for free, no cost to the employee. There's optional plans that workers can purchase that give them different benefits for premiums or co-pays or whatever, but the basic plan is free. This bill would have to include that the New York Health Act would be for free, not as it's currently written, which is that the employer will pay up to 80% of the tax and then the employee could pay up to 20% and so forth. It should be what we have now, which is free. The delivery of services under the free plan is based on providers in New York City. So unions that have members that live outside the city, those are higher cost plans. To offset those higher costs, unions have negotiated stabilization funds to deal with that. Well, how will those stabilization funds be funded in the New York Health Act? It's not dealt with at all. Will those funds be placed back into the wages of employees? Not dealt with. So there needs to be a provision that there'll be no diminishment of coverage, no increased cost sharing. Net to the city worker should remain the same or get better. It needs to be written into the law, not just laid out in purpose for the administrator to figure it out later. The payroll tax is estimated to be lower than the current cost to employers in premiums, but this is based on many factors that are fragile. First of all, the gradients are not set in the law. Secondly, the estimates could go underwater if the state fails to negotiate with the providers, or if the investors find a loophole, or if the companies find a loophole in the payroll tax, or if we can't keep the cost of pharmacy stuff down, or if any number of other reasons. And while many of us are skeptical that any of these disasters will happen, or perhaps we think we'll just cross that bridge when we get there, unions are in the business of predicting this stuff for their members over the term of a contract. And we think there should be a guarantee that the cost to our employers will not exceed their current cost. Because if it does go up, then they're going to try to get it from us again. And since we've already paid for what we have now, we don't want to have to pay again. Out-of-state retirees would not have coverage. Well, they say that unions can negotiate for coverage as they do now, but with only 20% of the people in the risk pool, the premiums are going to skyrocket. So who's going to pay for that? Is the New York Health Act going to absorb it? There's no provision for that in the bill. Universal quality of care. Well, this is deeply important, right? Is healthcare in Brownsville going to be the same as healthcare in Scarsdale? The current quality of service is largely deployed based not only on income, but also on race. Healthcare is a single payer system, cannot be provided discriminatorily. How do we provide a transition away from divergent care and make sure that everyone receives universal care regardless of income, race, zip code? Unions can advocate for workers by establishing themselves as care coordinators, as I mentioned before. This needs to be fleshed out, understood. What's their authority? How do they get paid, etc. We have a whole floor in my building. That's our benefits department. Those people could possibly do this care coordination. So how does that work? What about hospital funding, right? We have several thousand workers in my union that work for H&H, and that system relies on a patchwork of funding from federal, state, city government, DISH, DISRIP, Safety Net Hospital, Enhanced Safety Net Hospital funding, CHIP, HICRA. This whole complicated formula cares for people who need it, but it's often disproportionately benefiting private and more affluent hospitals. So how are we going to make that more even? Will the newly formed administration be like a commissioner and an agency that's appointed by the governor, kind of like the MTA? That hasn't worked so well in the past. How do we engage them? How do we enforce that? How do we make sure that there's no problems with that? We need a guarantee that the displaced workers get the jobs in the new field, not just job training. This will be a massive vacuum in our economy for all those employees of unions and insurance companies, doctors' offices, everybody. You know, they can't be just told, here, we'll give you some training and then go check in with the unemployment office. Unions have spent decades really trying to provide services to their members. The relationship between what we gain and what we lost operates like a seesaw. When we remove one side, the other side is left without a partner. If we remove the healthcare part, then we have to adjust the other side. So it either picks up the slack or recenters the gravity. The bill only deals with the healthcare part. It doesn't address the other side. That might be okay for those who don't have the other part, but unions do. And the last thing we want to do is take away things that are mandatory subjects of bargaining, move them to permissive subjects of bargaining or even prohibited subjects of bargaining. Most often we feel that we're best suited to bargain for our members rather than having wages, benefits, conditions dictated by the state. As an example, what happens if the current executive or legislature change in their philosophy? Now we lost what we had and we can't get it back at the bargaining table either. In New York City, we've been really able to negotiate far superior benefits. But we're not just fortunate, we're also driven and skilled and proud to have achieved what we have. It didn't come easy, and we have traded and negotiated for those gains. We've also been able to enact legislation at the local level to support even more enhanced benefits. Because sometimes those benefits are sort of purchased by a single interaction, such as allowing a temporary deferment of welfare trust fund contributions in exchange for a temporary prohibition of layoffs. But other benefits are purchased by an ongoing stream of compounding concessions, such as taking lower raises in exchange for keeping benefit levels, or maybe removing the out-of-network coverage to get faster action on the provisional promotional lists. Of course, it's easy to unscramble the egg when it comes to single interactions, such as the welfare trust contributions. And this is usually a simplistic approach suggested by those who lack the experience in this area. It's quite a bit harder to figure out how to replace the diverted wages that were exchanged to replace the enhanced medical coverage. How do you calculate that? Do you compound it from the time that it began? Do you start at today's wage levels? It's going to be pretty difficult to extricate that. To illustrate this a little bit more, people who do not have a robust bargaining or legislative advocacy organization are amongst those who need this improved healthcare the most. For public sector unions, we've certainly succeeded far and above other groups in maintaining and enhancing our benefits. So we don't want to have to renegotiate things that we've already achieved. We don't want to have to pay again for benefits we're already paying for. Why would we want to start double paying for it now just to get what we already have? Understanding this concept is more than just the unions are being selfish. Rather, it's a legitimate concern that must be addressed if municipal union support is expected. There's one caveat here. Unions, which have done so well up until now, can't maintain this forever. Healthcare costs rise, healthcare insurance rates rise, and there's not enough places to trim the fat to keep this going. The costs are running away like student debt. There's going to come a time in which these unions are going to begin to see the light at the end of the tunnel, and they'll start to look around for a solution. At that time, you'll see unions clamoring to read this bill, figure out what it says, calculate the cost, pressure the Department of Health for figures, demand legislators amend it, force an agreement on the tax levels, percentages, demand the savings that realize to be funneled back to their members. That's kind of what we do as unions, right? So we're seeing a little bit of this today, but not really enough. There's not enough urgency yet. But it's my prediction that until that happens, they will not give up what they have today. Until they see that they're at a dead end, they're not going to give up what they have today, take a chance on something that they can't calculate, can't guarantee, can't explain to their members. Another idea is for us to figure that out. What calculations do we have to know to prove that the current system is going to collapse? What do we know about the history of this bargaining, the trajectories? How can we interpolate what's going to happen in the future? We can't just use intuition. We have to use actual figures for these people. How can we get access to the actual figures so that we can speak intelligently with credibility? Because if we're viewed as self-interested outsiders, we'll lose. If we have bad figures, we'll lose. If we continue to tell them that they're wrong or that they're selfish or that they should be satisfied with just helping others, we'll lose. Lastly, the process in New York goes through the AFL-CIO. If our strategy is to circumvent the unions who object, I think that's a losing strategy. I think it will be more costly, more exhausting, more divisive, and I think it will fail. It may require several more successful elections to get legislature who doesn't care how badly the New York Health Act will affect union members. If, on the other hand, the strategy includes figuring out the actual costs on the other side of the seesaw and addressing them, then I think we have a chance. So I agree with a lot of the colleagues that are here that we need to keep the pressure on. However, let's not forget the other part. Understanding these legitimate objections from various stakeholders is also critical. If for no other reason than by amending the bill to address the issues, we can serve to remove some of the resistance. But also, when it comes time for it to start really moving, it will be a better product and it will benefit more New Yorkers. So I've provided some of my perspective from public sector labor, but it's certainly not exhaustive, nor does it cover other stakeholders, which are also critical. We have some momentum. This has been tried before in Vermont, been considered now in New York and in California. In both states, there's a supermajority of the legislature. And of course, there's now new hopes that come from the recent Georgia Senate elections at the federal level. And so as exciting as it is, it's still not going to be easy. So I'll end there and I'll be happy to take some questions with Gowri afterwards. I hope that was fulfilling.
Definitely.
Thank you, John. That was a big lot of stuff to swallow. So the way that we're going to handle the Q&A for people who were late and didn't know is Ting is going to be handling Stack. You can either raise your real hand, you can raise your virtual hand. or you could just write stack in the chat and ask your questions, or I know at least one person wanted to speak about his union. So thank you again to both of you, and here we go.
Julie, do you want to have Charlie speak first?
Charlie, do you want to speak first? Charlie is an 1199 person. You're muted.
You have to unmute yourself when you speak.
Yes, I'm a retiree. I worked in several hospitals, the last 45 years. I was a technician. And I'm just trying to take it from the rank and file point of view. And I think what John was saying is it's a lot of legitimate stuff. 1199, we have about 200,000 healthcare workers, and we're in the major hospitals throughout the state, with the exception of New York Hospital. We have half of it Presbyterian, and Sloan Kettering, which is an entity into itself. But the thing is that I just think in negotiations, we have a really good health plan, which basically the union manages. I mean, there are management by law, by Taft-Hartley, there has to be, half the trustees have to be for management. But basically the union really administers the plan. And the problem with all of this is that for unions, for every $100 1199er makes, the hospitals have to put in $33, around $27 for benefits, and about $6 for pension. So it's quite a burden on management, I must say. So the question is, how do you keep this going? And it's not easy, because we came very close to a citywide strike in 2015. I don't know if you're aware of that, but we came very close. They were after the benefit plan. And then next negotiations, they were after the pension plan. So it's a fight, but it's always a fight for unions. That does not change. So what John was saying is true. I mean, we have quite a plan, but the thing is, how do you keep it going? I mean, this is the thing. And of course, the numbers of unionized workers in the state is a clear minority. And it's centered down here in New York. And we do have other upstate hospitals, but nationally, only 10% of hospital workers are in unions. And that's about, maybe it's been very difficult in many other states to extend. So my point is that there are a lot of questions, but I think that we eventually in the union movement have to move in support of this. Now, maybe, like you say, with Georgia, maybe on the federal term, the federal government has the right to print money. We've seen that, and that would certainly, a national health plan, probably a direction I would hope this country would go in. If it has to go state by state, so be it. I think this is very important. We have these major hospitals in the city, but most of them really depend on Medicare and Medicaid funding. I know my institution, my ex-institution, Montefiore, 80% of their revenue is Medicare, Medicaid. The only major hospital in New York City that relies on private patients is NYU. Now they've expanded. That could have changed. As they grow, they grab up other hospitals, and perhaps that percentage diminishes. But even mighty Presbyterian New York Hospital, about 50% of their revenue comes from Medicare and Medicaid. So, you see already that they're very dependent on the government, and this notion that there's a lot of profit they make from from private patients, but they're all integrated into this already of this very inefficient system. So with 1199, the contract is coming up in October, and of course, a key player here is our dear governor, and that's where the pressure has to be put always to shake money out of them. The money goes to the hospitals, and then the union has to fight to get the money from the darn hospitals for our contract. And that's the way it goes. And that's the bind that we're in. Now, 1199 has sent people in the last few years up to Albany. It's not a tremendous effort, but I think legitimately they do support this bill. How much they could do? Okay, they could do much more for sure. But what faces unions? I mean, also it's a matter of COVID, getting members to accept to get the inoculations. And you would think that would be easy. No, it's not. I remember when several years ago when SARS came in, we had an enormous battle within the delegates, the shop stewards in Montefiore to get people to accept to get a vaccine, hospital workers. And this is also a fight, and protect, and it's very important, the health and safety. So I think that, it's true that, we have good plans, but I think if we look further down the road, unions really have to join this broad coalition to bring this in. It's the right thing to do, for sure, be best for our patients in these hospitals, and but it's also just for the survivability of unions. I mean, it's not an easy thing in this country to keep going and to organize. It's practically almost impossible to organize workers. It is extraordinarily difficult. It's practically illegal in this country, what we face. So I would say that, I hear many objections or questions that John brings up, but I think in the overall scheme, we really have to head towards some sort of a national health plan. Or do it state by state first, but I think it's the only solution for working people in this country.
Thank you, Charlie. Gowri and John, any response to what Charlie was saying? Any response to what Charlie was saying?
So yes, I clearly agree with what Charlie was saying in that I believe that, even though we might have passable plans now, things are constantly changing, which in my own time working at SUNY, I've found, our premiums have gone up, our co-pays have gone up. I think there has been a change in sort of in what we've received as services. And I feel like, there's no guarantee that we're going to have all of these things tomorrow. I've certainly am not a union I don't have the history of the union, thoroughly sort of in my head, but at the same time, I do look at technology and I feel that a lot of, there's going to be a move towards employing, like reducing workforce and employing technology in workplaces. And we're going to see that accelerate in the next 10 or 12 years. And I feel like we all, so I see job losses happening, and we really need, health plan that even people who are not employed anywhere can access. So I really do feel that this is imperative and things are not going to remain the same. But yeah.
Yeah, I think that what Charlie is saying is really important. I agree with all of it. And in fact, I would say that we all kind of know that the system is unsustainable. It can't go on this way. It's a runaway system. Mm-hmm. But there are some unions who may be oblivious to that. Maybe they're too busy negotiating over layoffs and this and that. They can't see things that holistically or that big, or maybe it's a small local that's part of a larger national union that's making decisions in DC or somewhere else. But some of the public sector unions, I think, understand this, because we really get into the nitty gritty when it comes to dealing with the municipality of New York City, for an example. And we do a lot of negotiating and a lot of wrangling. And so far, we've been relatively successful, right? So for an example, a month ago, we negotiated, all the city unions negotiated with the city. I mentioned it in my discussion that we would forego welfare trust contributions from the city until October of 2021. At that time, they would pay us back a third, and a third. So the October, November, December, the end of the year. But during this time period, they could not pay us into our trust funds. We run the trust funds and we run them so well that none of our members are going to lose any benefits during that time period. That, in exchange for that, we agreed to a no layoff clause that's good till June, and then it's also renewable for another year afterwards. So we have the opportunity to do stuff like that Whereas other places outside of New York City, even the unions don't have the ability to negotiate that kind of stuff. So we're really in a unique position where we have a lot of different options based upon our bargaining history. And so as a result of that, some of these unions feel like that it's not as urgent yet. It's not upon us yet. You know, it's going to be upon us, but it's not upon us yet. You know what I mean? That's what I think of that. The other thing that I think Charlie mentioned about unions in Albany and we're not that much of the population in general and so forth, all that's true, but nothing is happening in Albany if 1199 doesn't say it's going to happen. 1199 is a huge union. Often they work with the Greater New York Hospital Association, and when the two groups get together, all of the rest of the labor movement couldn't overturn that. So it's true that we're a small portion of the population, but we hit way above our weight, and we do have a lot of influence. And so there's no way to get this stuff done without the support of some of these unions.
Great. So next on stack, we have Earl followed by Mark. Earl, you have to unmute yourself, please.
Okay. Hi. Thanks very much, Gowri and John and Charles for speaking. And John, you mentioned that a solution, it seemed like one of the solution that you were talking about was to actually get all these figures and sort of predictions, trends that are happening and predictions of where these runaway costs are going, so that people can really see it. And I'm wondering, where can we find something, those things? Is that where we go to a legislator that might be able to put staff on this? Or is that where we go to even a federal senator that might be interested? I know there was this one guy called Bernie Sanders that seemed very interested in national health care. Some of these folks have some money and they could possibly hire staff to actually look into for New York unions and to make that prediction. It could be, a chart or something, and it would have to be accurate and as accurate as possible. And these are questions, a lot of the details haven't been worked out. All these details that you're talking about. I mean, I think Gottfried and Gustavo have been trying, but there's still a lot of questions. So, and people want to know. Everybody has these, or not everybody, but especially people that think about it more and that are at your level of thinking about this have these questions. So, who is it that we need to find to give us this information, and what will it take?
Well, there's two things that I'll mention about that. The first thing is that information, I would say, is largely private. In other words, it's information that's between an individual union and the employer, which could be the city of New York, or it's information between the unions, plural, meaning we have a committee called the Municipal Labor Committee, and it's made up of all the different unions that negotiate against the city of New York when we bargain contracts. And so there are figures amongst the bargaining teams as they talk back and forth and they price things out and they do all that stuff. I don't even have any of those figures, and I'm in the local. So I don't think they can be gotten through any government official or anybody like that. Maybe people in the city, the administrators or staff at the city of New York, because they're the employer, maybe there's a way to foil some of that information or to try to figure out what the costs are or whatever, but I'm sure that it would be a maze of information to try to figure it out and separate off and all that kind of stuff. That's
what about the controller?
Yeah. The second piece of it is that I think that a lot of these unions won't want to give the information up because they don't really like other people in their business. And so I think our motivation for trying to gather that information is obviously going to be, let's learn that information so that we can produce a cogent thought process, right? Connect the dots for folks but it has to be in the most accurate way possible, right? Because if we start connecting the dots and we miss a bunch of stuff, then they're going to just turn around and say, these guys don't know what they're talking about. And then they'll just dismiss us, right? So that part of it is going to be very, very difficult, but I also think essential if we're going for trying to get their support.
Okay, next on stack is Mark, followed by me. Have I missed anybody? Okay,
Hi, hear me?
Yep.
Hello? Can you hear me?
yes, you can, Mark.
Oh, okay, hi. I enjoyed this tremendously. In particular, John, you essentially spoke to exactly what I wanted to hear. What you said was a little bit depressing, I must say, from my point of view. I really, and I'd ask Julie to join me a little bit here. That talk that you just gave should be given at a PN, Physicians for a National Health Program, a forum where a lot of people have a lot of different thoughts, could ask you the questions, so we could all hopefully understand it a little better. I have just one comment that is pretty benign, and then one serious question. And my comment is, at the end, you said that one of the union's questions is, well, how do I really project? How do I know what's going to happen in the future? And I do think I do know, because if I look at a plot, healthcare cost over time, even it just has gone up relentlessly for the last 20 or 30 years. And interestingly, the ACA has dampened the slope. The rate of increase has gone down a little bit because the ACA has helped a little, but there's no question that there's no way we're ever going to stop the increase until we really get a single payer system and get profit out of it. But I guess that goes into your grab bag of, well, it's not immediate, and so the union people don't care. But my one question I would like you to elaborate on, because I don't understand it. You went on in the beginning talking a lot about costs and how now you pay nothing. And then we're going to make your people pay 80% and the employers pay 20%. I think I reversed that, but gee, right now that's true. But what happens when you have illnesses and co-pays and deductibles and out of network things? All these, that comes out of somebody's pocket, and you must pay that. And you have no control over the increase in cost, because we are still subject to the fact that there's no cost control. The doctors and hospital associations and pharmaceutical companies have total control over determining costs. So I don't understand your statement that says you're somehow going to lose money, or your union members are going to lose money if you go from your private insurance to non-private. Oh, and the other thing that has to be in there is, yeah, it's great when you're working for a union, but what happens when you lose your job? And then COVID-19 certainly is. I guess it's that part of your argument that I don't understand.
Yeah, well, I mean, I agree with you. And when I do the math, like for an example, you brought up a few things, but I'll bring up a few other things. I work for a labor union in New York City, but I live in the Hudson Valley. And when I went to go use my insurance, I have a very good employer. I have very good insurance, maybe some of the best insurance. And I went to go during a weekend. I had a problem, a urology problem, and I thought I was going to have to go see somebody. But to go to the ER, if they don't admit me, it's $150. On the other hand, if I go to an urgent care, it's $20. So which one do I do, right? And then, oh, wait a minute, in my town, there's 7 urgent cares, but my insurance is only taken by 3 of them. The other 4 don't take mine, and I have no out-of-network coverage. So now I'm throttling my care. I'm trying to decide, do I want to wait till Monday and see if I can pee until then? You know, all that kind of stuff. That's, you put a price on that stuff, right? And I'm supposed to have really good insurance, right? So what you're saying is absolutely right. When somebody from the union or somebody from the employer says, currently the price is free, it's not really free, right? Because it's not, you're not free to go anywhere or do everything you want to do. However, when you work for the city, it's in the city charter that the benefits are for free. They don't cost you anything premium wise, right? Over time, and by the way, there's no copays or anything else with the free plan. Okay. But if you don't want to go to H&H, or you don't want to go to the local, you know, Healthplex storefront place, you know, then you have to buy the plan that has the premiums or it has the copays or whatever. So unions will negotiate with the city to allow options. Okay, you can have the free plan, or you can have the one with more premiums and less copays, or you can have the one with more copays and less you know, there's a couple of different plans you can pick which one is your doctor in and blah, blah, blah. Oh, but now that really stinks for our members, because now a lot of the members are getting healthcare that they have to pay for. So what do we do about that? Let's create a welfare trust fund. We'll have the city put in a certain amount of money per head into this welfare trust fund. On top of that, let's get a stabilization fund to even out the high and the low parts of prescription costs and all. So the city puts in that money into those other funds, and there's this patchwork and layers of different stuff on there that eventually the member really doesn't pay anything, because even the premiums and all that stuff gets reimbursed to them, right? And so all of that stuff is the product of union negotiations over decades, right? We've done this and we've created this system where it ain't great, but it's greater than everybody else's. And to the member, it seems like it's free, but all that money comes from diverted wages or diverted other stuff, right? You had to give up something with the provisional list, or you had to give up something with promotional titles. You had to give up something else somewhere. So, okay, fine. If we want to go to a New York Health Act, and we want to go to single payer, we want to cover all those things. Let's cover all those things. But do I get back the wages then? Do I get back the rules for provisionals? Do I get back all that other stuff?
But to me, again, I'm not you, but that doesn't seem reasonable. You're getting what somebody else paid for. That argument that if it's going to be a little cheaper, the money should somehow come back to the.
Well, the other part of it is this: not only are the unions and the members going to feel like, well, I already gave up something in order to get those benefits. Now I'm going to get those benefits and I want to get the other thing back. That's one part. The second part is, in addition to that, going forward, nobody's going to have to pay premiums anymore, but now people are going to have to pay the tax, right? And the tax is going to be a gradient. There's estimates for the gradient. The RAND study, they did it where it was $25,000 and less.
Yeah.
Paid $25,000 up to a certain amount. It was 3% and so forth and so on. But out of the amount of the premium, the employee was going to pay 20%, the employer was going to pay 80%.
Right.
And then when we talked to Dick and Gustavo and we explained this to them, they changed the bill around to say that unions could negotiate a sliding scale for the 20%. So we can now go back to the city and say to them, instead of us paying 20%, you paying 80%, we want you to pay 100%. But now we have to negotiate that. So we've already negotiated to have free plans with all the layers of stuff. Now we got to go back and negotiate again for something we already have, right?
Yeah. It's hard to argue that, I guess.
That's how they feel about it. I'm not trying to convince you.
No, I agree.
My purpose is to really show people these are the things that union leaders are looking at. And I believe it's valid for us to say, I think you or somebody else also asked the question about costs going forward. I think it was you. And that's what I was talking about, was not the cost going forward of the current system. What I was talking about is when my president says to me, well, John, if we scrap the plan we have now and we do the New York Health Act, and 6 months from now, it gets passed in the legislature, and a year after that, they finally get the Department of Health and the Department of Finance to figure out how much it's going to cost. And 2 years after that, they finally figure out how to implement it. How much is it going to cost my member, who's an administrative manager? Right now, that member is getting this coverage for this amount of money. What are they going to get then? What coverage for what amount of money? I want to be able to compare the two. Are they apples and apples, oranges and oranges? What are they? And the answer is nobody knows. Nobody knows what it will cost. Dick Godfrey doesn't know what it will cost. Gustavo Rivera doesn't know what it will cost. Nobody knows what it will cost. What they're saying now is, let's pass it, and then later on we'll figure out what it's really going to cost. And for a union leader, they can easily turn to their member and go, you want me to support that? Not knowing what it's going to cost? If you do, that's okay, but that's on you, not me, right?
So in what you're saying is there's the argument that the rank and file would benefit and would support single payer is probably not right. The rank and file, if what you're saying is how they see it, they would actually be for the unions rather than for us.
Some rank and file support it and will go to their leadership and say to them, how come you're not supporting it? It's going to be great. Look at all these things. You're not going to have to bargain and blah, 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 and all that stuff. All that union leader has to do is turn back to the member and say, what's it going to cost you next year? I don't know. Well, I don't know either. Well, they say it's going to be cheaper. Yeah, they say it's going to be cheaper if they can negotiate the pharmacy costs, if they can negotiate the provider costs, if they don't have any migration of rich people going out of the state, which I think is really a boogeyman. I don't think that really happens, right? If they have no tax avoidance, right? I mean, a lot of the money that's going to come in is going to come in from capital gains. So what happens when the rich people figure out where the loopholes are and they start paying less in taxes? How much less would it be before somebody's going to have to pick up the slack somewhere? And who's going to pick up the slack? Is it going to come from education, or is it going to come from higher town taxes? Where's it going to come from? It's got to come from somewhere. Are the employees going to have to pay? What if you're like me? I'm retired from Verizon. I get medical benefits as a retiree. Does my employer, CWA, are they going to have to pay the payroll tax for me when I already get benefits because I'm retired from Verizon? How's that work, right? Or what if I spent my whole career working for the city of New York paying nothing in premiums? Now I retire, but in retirement, I go get a job. Now I have a job somewhere. Am I going to have to start paying 20% even though I already have benefits? How does that work, right? So there's a whole bunch of questions that are unanswered that really need to be developed and figured out. And the savvy union leader is a person who gets into their position because they really try to cost this stuff out and figure it out before they negotiate. And they're much better than we are at negotiating contracts, right?
Well, you taught me.
Mark, you done? Okay, on the stack, we've got a few people. We've got Tim, followed by Julie, followed by Holly, followed by me. So Tim, unmute yourself, please.
Hi. Yeah, I wanted to ask a slightly different question. If we look at the counterparts or the opposition to this in Albany, of course, primarily it's pharmaceutical, the insurance industry, providers to a certain extent, although not universally, and so on. And what you're saying, what John is saying here, as I understand it, is the unions are clearly of various minds about it, and for all these reasons that he's argued very compellingly. I wonder if there's some intermediate steps, and I'm not talking about an intermediate system, but just steps. And I'm thinking of a list that was compiled by Gerald Friedman, who's a health economist who costed out this system a few years ago. I was trying to find it as we're talking here, and I couldn't, but he had a list of a dozen measures that could be taken. And my question is, are there things where we could be on the same side that would move us in the right direction and would obviate this division of interests that we're hearing about today. Because, you know, and I'm even thinking of the strategy put together by the prohibition movement, unfortunately, because they were quite good, where they said, you know, we are not going to get everything we want, but we're going to try to figure out things that we could acquire that would move us in the direction. For example, federal income tax. That was backed by prohibition by the prohibitionists, because it eliminated or alleviated the government's need for excise taxes on liquor. So they said, yeah, we're for the federal income tax. So anyway, that's the parallel that I was thinking about. Any ideas on that?
You know, I think that there's a lot of creative things that could be done, and I think they all fall under the philosophy of if we have a choice between a system in which people who have no insurance or crappier insurance get more, and people that have the best insurance get to keep what they have, and everybody pays a little bit, that's good. What if we had a system? Wouldn't it be better if all the people that have no insurance get insurance, if the people that have crappy insurance get better insurance, and that the people that have the best insurance don't have to pay more? Isn't that better if we can do it? And if by doing it, it means we remove the resistance from getting it passed, then that's even better, right? So I think that's what we have to strive for. You know, the obvious losers in this is going to be the insurance industry in New York State, right? There are other people that are objectors besides labor groups. And by the way, you're right. It's not all labor groups, and it's not even all public sector labor groups. And it's not. And there are some private, a few private, some of the Taft-Hartley groups like trade unions and stuff like that. I mean, for those guys, if they have a benefits center and the member retires and stays in New York State for 10 years, but then eventually moves to Arizona, how are they going to pay to have that person in Arizona to get coverage? And right now, the benefits are provided by their union. It's not provided by their company. So that means the union is going to have to pay extra money when they have a retiree that moves out of state, where they don't have to pay extra money now, right? So there's a lot of different interests that are there. We just got to figure out what all of them are, and we have to make a commitment to say we'd rather everybody gets made whole, including these unions. And if we strive to do that, then the only person that loses is going to be big insurance companies. The only other caveats I think that are in there is, number one, small business. Right? Anybody that doesn't pay, that, you know, has 5 employees, 10 employees, that doesn't pay any health insurance right now, those people are going to have to start paying a payroll tax. So where's that money going to come from? I don't know the answer to that. And I'm sure that a lot of those people, if they're incorporated into a group called the National Federation of Independent Businesses, that group I see in Albany all the time, if they're part of that group, then they're independent, but they're organized, you know, so they have some influence in Albany. And if they object to it, they object to it. So that's another group. Another group is going to be these gig workers or independent contractors, you know, Joe the welder or Bob the plumber or the Uber driver or whatever. All those people are going to have to now pay as an independent contractor, like how they have to pay for workers' comp for themselves. They have to pay for unemployment for themselves, even though they're a sole proprietor. So they're going to have to pay the employee and the employer part of it, where before, you know, maybe they had health insurance, maybe they didn't, you know, who knows what they were doing. Maybe they had something on the essential plan or blah, blah, blah. So there are other groups that have some objections that we should really look at and try to figure out. I know this particular forum is about labor, but I just think that that if we take that commitment, that I think we'll be heading in the right direction. I also feel, and I said this in my remarks, that this is an unsustainable system, and I think that unions eventually are going to come to the realization that that they can't, even they can't sustain it any longer. That could be a year from now. It could be 2 years from now. When that happens, you're going to see a lot more churn, a lot more stuff going on, a lot more people examining it, looking at it, digging deeper, all that kind of stuff. And I think that's when we have to be ready. I think by that time, we got to look through all the problems, see what we can fix before we get to that point, leave only a few big things left, fix those last couple of things. We're not going to fix everything, right? And eventually it's going to get to the point where it's good enough and it'll move forward. But it's not going to happen by us trying to circumvent these unions. It's going to happen by us swimming with the river.
Great, so stack, we got Julie, Holly, and myself. Julie, you're up.
Yeah.
I don't mean to take all the questions. Gowri can answer some of this too.
I am just, I don't feel capable enough to answer many of these questions because I don't know the details. While I am in the VP for my union, the kind of issues I deal with are kind of not quite related to the sort of nitty gritty of the economics you're talking about. So this is great. I'm learning a lot. Thank you.
Okay.
Julie?
Yeah, so I was going to say, I think just kind of looking at all of this, John, your position, seems to be, let's understand what the problems are for the unions. Let's understand what the problems are in other contexts for other people. But I still think, it's kind of our work to point out how, in the end, a single payer system is going to save lives and money. So I think we need to listen to the concerns. I think if we carve out too many little holes there, we're kind of dooming ourselves because the funding becomes less capable of being able to take care of everybody. So I think, in a way, it's terribly important for us to understand what these objections are, but I don't think it has to change the focus of our work, because I think when we speak to people in labor or in anywhere about what this really would provide to everybody, saving lives and saving money, I think we just have to continue to take our time and listen to those things. And the other thing I was going to say earlier when I first got on STAC is that the union plans, as good as they are, I'm not aware of any plan that really covers long-term care in this unending way that the New York Health Act would. Now, to fund that, we do need to have everybody in, but I think that's a huge deficiency in the healthcare system now. I think we need to point to other countries where taxes are spent differently and the single payer systems that do work. Charlie was talking before about whether to start on a national level, which hasn't been possible. Canada, of course, we know started province by province, and it seems as if it's more likely for that to be able to happen here. But I think we just as people in this country need to understand that systems work in other places and that people are really suffering. And this is a moment in our history where there's so much suffering from lack of health care and from this horrible marriage between corporations and healthcare. So I totally appreciate what you're saying, because I haven't heard those policy arguments stated in that way. And I think we need to know them and know everybody's concerns. And there are so many concerns, the concerns you also stated about, where somebody lives and what their zip code is and what their race is and what providers would be taking care of people. So there are, on so many levels, we need to address the inequalities. But if we really want to create something where we give people what human beings deserve, we need to listen to this, and we need to also go beyond it so that people on a personal level understand, what they're going to be getting, which is care from cradle to grave, including long-term care, which is just killing families. And, it's part of the horrific situation that our system allows to go on and to have it be for profit. So it's my thoughts.
For sure, I agree with you wholeheartedly. And in fact, I think that what you're presenting is a value argument which I assume everybody here agrees with, and possibly everybody everywhere that thinks about that we should have this single payer care, because we need to have coverage for everybody, saving the lives, making sure it's equal treatment for everybody, no matter where they are. And the long-term care question also, which, I'm sure the long-term care was not in the bill until last year. Prior to that, it was added in, and they kind of made some calculations of what they thought it would cost. And all the unions that I know of went back and called up their fund administrators and said, we have long-term care in our package for our members. This is how much it costs per head. This is what Dick Godfrey is saying it's going to cost in his plan. Is that possible? And the insurance company said, no way, no how. Right? Now, of course, that's the insurance company, right? So that's going to cut into their business. But at the same time, these are the experts that we as unionists rely on and deal with and partner with and so forth that manage our benefits. So what other experts do we go to ask them whether it will work or not?
Well, we can go to economic studies that we have, the RAND study, and RAND is certainly not a left-wing group doing this study, but they did a study that included how the bill now has long-term care in it, and still it saved money.
Yeah. The RAND study also had left a lot of room for disasters. One disaster or another could happen and could throw off their numbers. A lot of the stuff that they said in the later pages, 20, 24, 29, in those areas, when they talked about some of the stuff that I mentioned, right? Like what happens if there's some migration of providers they described. Like, in other words, what if some doctors who are presently in New York decide to pack up and go open a practice in New Jersey instead? And then we don't have enough doctors left, right? Now, I don't know if that's really likely, but that's kind of some of the stuff that they were describing. Then they started talking about what if there's tax avoidance issues and so forth. Not people moving out of state like some people talk about all the time, but instead of that, just people that figure out loopholes or different stuff like that. A year or 2 years after the New York Health Act goes into play, you could have people offering up pilot programs through the IDA like they do now, right? They give people mortgage tax and sales tax and so forth, incentives to bring businesses to your town. So what if they offer that up to Amazon? Yeah, come on and build a warehouse. We'll relieve you of the New York Health Act taxes for 5 years if you come and build your building in our town. That stuff happens all the time. So who's going to pay the difference then? And the RAND study really talks a lot about the possibilities that the numbers that they put up are highly dependent on fragile things that are not firm, that are not constant.
Okay, so moving right along. Next on stack is Holly, please. Unmute yourself if you would.
Yeah, thanks very much to John and to Gowri. It's just incredibly informative, and I'm not even sure if I want to go forward with asking this question because I'm looking at things from perhaps a too abstract point of view. John has given us so much detail about the ins and outs and the differentiations between one union and another union and the achievements in one place and other achievements in other places. And that is, that of course, that would all have to be known. I'm in Ticonderoga. I am going to be talking to people in USW at the tie paper mill. And so this is extremely important for me to know as much as I can before I start that up. So I do thank both of you. My question, though, is that, to put something in the perspective of people who are organized, unions are groups of people that are organized. They have hierarchies, I assume. They have and kind of unified voices, spokespeople, and so on. The people, which is basically what we are, we don't have a CEO, we don't have a board of directors, we don't, so we're kind of dispersed, and then we try to make up for that through these kinds of grassroots organizations, which are great. But the idea of that of being able to form an organization, and then you're forming your organization over against something else. And I think I don't want to downplay the fact that that's an opposition. And one of the things I'd like to ask John about is what is, as a union, unions are on one side of a divide, corporate ownership is on the other side of the divide. I almost had to smile a few minutes back, John, when you said, well, the only people that will hurt in this is insurance companies. And it's like, oh my God, that's like, Godzilla might feel some pain here. Obviously you move toward a legislator, and that legislator is going to be pressured not just from the people for all of the good reasons for single payer, but they're going to be up against lobbying and pressures from a corporate structure. Now, as you are, as union people, you're in, a kind of relationship with that corporate structure. Many Americans think that you have got to support corporations, large corporations, because that's the American way. And that is really baked into what it means to be a red-blooded American. But even beyond that, there's obviously is the lure of these tremendous pots of money, if you want to put it crudely, right, that are under corporate ownership. Now, how do you maybe this is not relevant here, but I would think it would be. How do you approach? What's your attitude toward those ownership, those very, very powerful ownership groups that are called corporations? And it's not just insurance companies, as you know. It's private equity. It's privately owned hospitals, as Gowri made note of. That's right now I'm getting my health care through a hospital system that isn't even based in the state. I'm in Essex County. My healthcare comes from Vermont, and that is that's not a big medical providing corporation, but it's a lot richer than I am. And anyway, okay, John,
Yeah.
if there's an answer,
Gowri. You bring up a lot of really important points, and the way the relationships are intertwined can be confusing, it can be interesting, but I think it's less through loyalty or nefarious means, or because the union leader wants to get a free steak dinner every once in a while from the insurance person. My experience is I don't see any of that stuff that happens, but there are some interesting relationships. Like, for an example, mine is a public sector union, and there are other public sector unions. So we don't really deal with private corporations as an employer. But when we go to lobby in Albany, I see the lobbyists from the insurance companies. They're arguing with the lobbyists from the hospital, right? Just in my area here, we have a Montefiore hospital that's here, and they're negotiating with United Health over the network charges, the in-network hospital fees, right? This is a contract that comes up every 3 years or so between the insurance companies and the hospitals. And the insurance companies, which make a margin of profit of 20, 30, 40, 50%, keep squeezing these hospitals that make a margin of profit of 1%, right? They're squeezing them over and over and over again because they want the hospital to charge less money, not because the insurance company cares for me as the patient, but they care for themselves. They're trying to pay out less and still charge me the same amount. But what happens? They'll go back to the public sector unions and say, if we don't get this law passed, we're going to be in trouble as an insurance company, and the rates to your members might go up. So unions get involved and they try to do what they can to help, because they're trying to help their own members, not because they're trying to help the insurance company. Right. And then as a result of that, you develop relationships over time, and you begin to understand one another's business and all that kind of stuff. But it's not you know, everybody's in bed against the citizens that don't have coverage or something like that. You know what I mean? So yeah, you bring up a very important point, and single payer health would do away with all that, right? It would do away with all the torture that I had to go through to decide, did I want to keep my retiree benefits or did I want to keep the benefits from my active employer? Well, which ones, how much will they pay for my wife's insulin, and how much do they pay for my sleep machine, and I had to go through and figure out, but at the end of the year, which one would be cheap. Yeah, I pay more in copays here, but less in premiums there. And I mean, that's completely torture over and over and over again, every time you do this sort of stuff. And this would do away with all that stuff. But none of that is going to convince the public sector union why it's better for them to have their members pay more for the same benefits. And
What I think I was thinking about, how do you approach a legislator who is under a lot of pressure from a corporate and wealthy, very wealthy corporate organization. Even as unions, right? You are, I'm sure, right? Always you have that in mind, that person or those legislators that you're talking to are under a lot of pressure from the other side that really does not want to see single payer happen.
Sometimes it's the other side, but sometimes it's not. Like, for an example, there's a brother here from 1199, and 1199, which is a huge healthcare union, is often on the same side as the Greater New York Hospital Association. So the two of them, for an example, I've been trying to get safe staffing passed in New York State, amongst other things, for 10 years probably. 1199 and Greater New York won't support it. So it's not going to get done. And that's a union with the company together against all other labor and against all other companies, right? So you never know where the alliances are.
Okay, if there's nobody else who wants to speak about that, I'm on stack next. So does anybody else want to speak about this? I don't see any hands. Okay, so I've got one comment and one question. The comment is that, and we should do this.
This is the scariest one of all night, by the way.
The comment is that I think as activists, one of our many chores is to develop plans for showing businesses that the Health Act can be good for them. And that's not true for all businesses. It's not, but it is true for some. And the details, of course, are where the devil is, but nevertheless, you can make that argument and they need to hear it. They haven't heard it enough. And maybe we'll do a meeting on that. So my question though is following up on Tim's suggestion about steps we can take to get there. And it's one that people have avoided doing with good reason, but I want to bring it up. What if we gave each union the option to be in or out? What would be the effect on the act itself if, let's say, half the unions or some number said, okay, we're going to be out? And I'm not sure, there's a lot of thinking would have to go into what does that actually mean, because it would mean keeping, for instance, some insurance companies who those unions are using, selling, but only to those union members, and it would be tricky. But nevertheless, is that a possible step for John and Gowri in your thinking?
Actually, I was just thinking about that as John was speaking. It almost sounds like a public option might be a third way. Like, it's like you either choose to be in the public option that everybody else shares, or you, not an individual public option, but collectively unions can choose to be. In fact, that's exactly what I was thinking, because I had not thought about the details that John just brought up about some unions. I can tell you that my chapter is totally convinced within SUNY New Paltz that we ought to move to a single payer healthcare, only because we have a vast army of part-time workers and adjunct teachers who never know if they're going to make those two courses that would allow them to get healthcare. Mm-hmm. So there's a whole lot of them for whom it's a very anxiety-provoking semester to look forward to the next semester, because they don't know if they're going to be hired or not. In fact, this semester we had to, because students are not coming back in the same numbers that they were last spring, we had to cancel sections of a very popular course. We had like 12 sections. It was reduced to 6. And there were a whole bunch of adjuncts who had to be now not unemployed in terms of, in our university. And so, in fact, a couple of them just like were saying that they were relying on employer provided healthcare for themselves. So I can tell you from our chapter point of onwards that we are sold on single payer healthcare, and we believe that that's where the future workforce is headed with part-time workers, and sooner or later it's going to affect all fields, and we ought to be prepared for that by laying the groundwork of a single payer healthcare system now and not wait until the disaster has hit us.
Yeah, I believe that that is exactly true, and I would say that if you first of all, I don't think that you can have the New York Health Act and have different unions opt in or opt out. In fact, I think there's a lot of municipal unions who have said that. Some of these groups, like that group NICEPEC that you had to look up, Julie, is this Public Employees Conference. It's basically us, 1180. We have another local that's 1182, which is the traffic and parking enforcement in New York City. And then there's NISNA. And other than that, the rest of them are all, Arlington firefighters and NYPD and state troopers and lieutenants and corrections and, a lot of these uniformed services, right? So basically, they came out and said, do whatever you want, have single payer if you want, just carve us out of it. But the problem is, if you lost that many people, the system wouldn't work. There wouldn't be enough revenue coming in. So
that's my question, because my impression is that only about 7% of workers are unionized. That may be an incorrect number, though.
That's a private sector. In New York State, the public sector in New York State is about 36%. So the total between all of them is like 26, 27% of New York State. Mm-hmm. And really it would be some of the public sector unions that would opt out, not the private sector ones. So that's a larger percentage. But the revenue to support this has to come partly from employer and employee, but a large portion of it also comes from capital gains. There's that other funding stream that comes from capital gains. So, any disruption in the amount, and that's why I was saying before about the RAND study, if you go back and look at some of that stuff, you'll see that it won't take too much disruption in the revenue coming in before it would no longer be feasible for the state. And then what would they do? It would collapse on itself. I mean, even with saving so much money in administrative costs and profit to the insurance company and all that stuff, it's still a pretty close margin, and it wouldn't take much to upset it. At least that's what I read.
Somebody has a question, Stack, about NYSUT, which the public school teachers, I think they're against it. Is that correct?
I don't remember now. NYSUT, AFT, UFT.
I remember they're against it.
Yeah.
No, I know they're against it,
Yeah.
but are we counted as part of the public unions?
Mike Mulgrew is in the public unions, but I don't know if that's the statewide union or if that's the city union. Mulgrew.
City. It's a city.
Actually, I have to correct that. I think NYSUT is for single payer. I don't think they're against single payer. In fact, I just looked it up, and it says the 600,000 member NYSUT reaffirms single payer support.
Oh, that's good.
It's because the districts can't afford it, especially the retirees. In our contract, we have it forever. And it for a small town, especially, we make up a huge percent of the budget.
Mm-hmm.
I mean, the other thing that I'll mention that perhaps everybody here already knows, I don't know, but I mean, this bill has been around for a long time. It passed over and over and over again in the assembly. Well, it's been introduced over and over again. It passed, I think, 4 times in the assembly. But even in the Senate, a couple of years ago when they were under Republican control, the Senate health chair was a guy named Kemp Hannon from Long Island. And, he basically took the bill and said to various legislators, including one in Poughkeepsie, whose name is Sue Serino, yeah, go ahead. You want to co-sponsor it, support it, do whatever you want to do, if you want to show off to the constituents, but you don't have to worry because it's never coming up for a vote. So even though she's a Republican, she co-sponsored it. And then, a bunch of these healthcare unions started to support her. And I said, she's not being genuine about supporting it. However, what happened was 2 years ago when the Democrats took over the Senate, everybody was all giddy, right? They figured, hey, we have a bunch of these progressive legislation, including the New York Health Act, and they're set up like dominoes and they're all going to fall. Not so fast, because all of a sudden, even the ones in the assembly that kept saying, yeah, I'm for it. Now that it had a chance for a real vote, they said, let's go back and look at it again. Let me go back and call my friend in the union. Let me call the guy in the insurance company. Let me call, and they started to hear all these objections, and all of a sudden they went lukewarm on it. Even with the supermajority that we have now, I'm not convinced that's going to be too much different. I know a lot of people who think that it is going to be different, that we're going to be able to pressure some of these legislators to just move forward with it. But I still think it has the same problems and the same objectives, some of which I've described from public sector union perspective, but there's other places and other objections from other places that I think need to be dealt with. And I think if we deal with those things, we're going to end up with a better law, rather than just trying to force through what we have now. That's an opinion. So, you can take it for what it's worth.
So here's a quick follow-up. John, I don't know whether you have at your fingertips or if anybody on the call has at their fingertips a notion of the numbers of union members who would be under New York Health if the unions took the positions they currently take with regard to it. So in other words, how many people would be out? So we could go to Dick and Gustavo and say, look, what would happen if we did it with these numbers instead of the other numbers, just as a way of moving forward?
I don't know the answer, but I know that I got some information not long ago from Misha, who's Dick's, and it had, I think it's the old list that they had of which unions were in and which were out. I don't think it's accurate. I think it's the old one, and so it's not really that helpful. And if they don't have a list, then I don't think anybody does. You know what I mean?
Yeah.
Other than one of us going to each one of the union's websites and seeing if it's published on there, or maybe calling up the union itself and asking them for a position or whatever, but somebody would have to do that roundup work,
Well, maybe that's something that some of us can take on. I was hoping the Labor Posse would do it, but is there anybody on from them?
I think
Who's here?
Ellen is on.
Ellen, are you here? Oh, yeah, she is.
Well, John's in the Labor Posse, which is not called the Labor Posse.
I know. I can't remember the new name. Sorry.
Labor Activists for New York Health.
Right.
I mean, I started this process by thinking maybe I could round up that information and all that kind of stuff, but I don't know that I can credibly talk about anybody else's union other than mine, and only sometimes can I talk about it actually representing my union, right? So I can tell you about my experiences and my opinion and all that kind of stuff, but I can't go to the corrections officers union and say, can you give me some information and blah blah blah. They're going to tell me to go piss up a rope just like they would anybody else, and especially if they thought I was gathering information to bring somewhere so that people could strategize on how to change their mind about something. So it's a difficult position for me to be in.
So perhaps it would be possible, maybe you have access to contact information that some of us could form a committee and start making phone calls or so forth?
I don't think I have any proprietary contact information.
Well, yeah, I wouldn't expect proprietary, but maybe there's a list somewhere of union contacts.
Not that I know of. In fact, even with PEC and even with the MLC, the Municipal Labor Committee, I've gotten copies of letters that they've put out. They don't even put contact information on their masthead or anything.
Top secret organization.
Christine, I think you were next on stack. You're muted.
Thank you very much, and I appreciate your speakers' very informative discussion. But one thing is, I think between Rivera and Gottfried, I would check with Gottfried because he seems to be the one talking a lot more with unions, and he may have more accurate information about who's in and who's out. That's one comment, because based on discussion I had with his staff, they seem to be much more up on who's on the discussion and the arguments. The other thing I wanted to say is I can see that there are two issues. One is the question of principle. The law is a question of principle that we're asking to approve and to endorse. And the points that John raised are a question of implementation. In other words, how much will it cost and so forth. I think we have to accept that it's two steps. The first one being the general principle of being available to all people at a reasonable cost, because we're eliminating the profit motive. And so it stands to reason that it will be less expensive. There's no way it cannot be less expensive. And the other one is to say, well, before I join, I will have to look at the implementation. And that could be a second step, because it will come up, it'll come up in the various committees. The Senate hasn't even discussed it out of the Health Committee because they didn't have the majority. So it has to go from the Health Committee to the Budget Committee to the Ways and Means. There's a lot of steps that are required, but we need to have an understanding that the principle is what we're voting for in the Health Act. And to me, that's the most important issue, because, I've cared for a woman who was a union member, a union activist. Her union died. She was having a pension of $100 a month because of this. So, I mean, you can't have benefits depending on an employer or a union. It has to be some other entity, the same way Medicare is some other entity, which is a government entity. So that's all I wanted to share. Thank you very much.
Thank you.
Yeah, I think that's a really good point. And I think my local is one of the few public sector locals who take that stand exactly, which is that we support the Single Payer Act, whether it's the New York Health Act or a federal plan, we support that principle and we want to get that done. But at the same time, we're interested in the details because we represent union members and we have to know what it costs and what it's not going to cost and what you get and all that stuff. And that's the stuff we do for a living, right, for members. So we're interested in both parts of that.
But can I just say that it's not going to be the Health Committee in Albany that's going to be able to look at that. It has to go to another committee to discuss, right?
Yeah,
that's the problem.
And along the lines of what you're saying also, that it kind of goes through the system and there's a lot of eyes on it, a lot of people looking at it and staff and lawyers and all that stuff. My union is about 9,000 people and maybe 85% women and people of color. And so I do a lot of work on gender and racial equality issues. Last year, we got 3 bills passed. One was to ban the salary history question, but 2 of them were on wage equality issues. One in the private sector in the labor law, one in the public sector in the civil service law. And those 2 had to travel separately because they're changing different parts of the law. They go through different committees, they're enforced different ways and so forth. The private sector one, we made it through both chambers, all the committees, on the floor vote, signed into law, no problem. The other one, for the public sector, basically we were redefining New York state law to match the federal law to say that all protected classes should be paid equally, not just gender or race, but all of them. And when we made it through the committee in the Assembly, which is the Government Employees Committee. Then we went from there to Finance, from there to Ways and Means, there to the floor vote, and it passed, right? In the Senate, we went to Civil Service Committee, and then to the Finance Committee, then to the Rules Committee, then passed on the floor for a vote. We got it to the governor's office. Now it's in the gets delivered to the governor's office. In the middle of when the bill was there, his staff changed, right? So some of the attorneys left and the new attorneys came in. The new attorneys came in and they found a problem with this bill that I didn't pick out. None of our staff picked out. None of the committees picked it. Nobody picked it out. And in the end, what happened was we cut public unions out of the bill. So it became an equal pay bill for everybody except public unions. So basically we did all that stuff and it didn't even help any of our members because we have those bargaining rights. We have things that are mandatory subjects, but now all the other people that work in the public sector in all of New York State are now protected by this new law. And so it's a demonstration and a reminder for me that sometimes I think everything's sailing through and it's okay, but there really could be a disastrous boogeyman in there somewhere. And I'm glad that they found it. And, you know, to your point, you know, this could happen anywhere along the way, right? So, I mean, there are a lot of eyes on it. There's a lot of people looking at it, but people miss stuff. Even lots of people miss stuff.
Is there any further discussion? I mean, the night is getting late. This is fascinating for me. I mean, I think it's kind of different from our usual emphasis on what do we do as activists, although I think that to Christine's point, that's where we really are anyway. And I think we all agree with that. So does anybody have any more questions? And I think, Ting, you had some announcements about action items, but does anybody have a final question for our two speakers? Okay. Ting, you were going to.
Well, just very briefly, the campaign is going to be working on phone banking to, if you don't know already, to selected districts, to individual voters in those districts to pressure certain senators, maybe some assembly people, including Stuart Cousins and Heastie, fairly soon. That's going to begin, I'm guessing, around next week sometime. So if you go on the CNYH website, you'll find a way to sign up for that and get involved. There'll be both phone banking, texting, and maybe some other contact methods. I'm not sure yet. And I'll put a link for that in the minutes when we send them out to you. That's all it was. Thank you.
I'm seeing in the chat from Christine interested in John's statement. Christine, are you here someplace? It's hard for me to, there you are. You moved where you were when other people left.
Yes.
So do you want to ask John what you're interested in?
Yeah, no, John, is it possible to have the text of your statement? Because there's so many details, as was mentioned by other participants, there's a lot of detailed information that, you know, I didn't know about and so forth. And I need to better understand all these issues to understand what's going on. Is it possible to have that statement?
Yeah, what I'll do is I'll review it with my leadership first to make sure I'm not handing out anything that's too proprietary. I don't think so, but I'll give them the option of doing that. Maybe I'll truncate it somewhat and kind of put it in a list or something like that. If you want, I'll get it to Ting, and then he can pass it on or whatever. Is that okay?
Thank you.
Perfect.
That would
Thank
be
you.
great.
I mean, actually, I was thinking, John, essentially you just gave us a master class in understanding some of this stuff. She's right. Christine is right. We really need to review it.
And don't make the mistake of thinking that that I don't think that we should do the phone banking and the pressuring of the leaders and all that kind of stuff, because that's an essential part of this, that without which we would never have the conversations of trying to figure out the details, right? If people aren't clamoring and pushing and driving and whatever, then the legislators are not going to come back to us as unions and say, hey, listen, I'm getting a lot of pressure on this. We're going to have to figure out some resolution, right? That's what will result from it. And the faster that we can get unions to do that, the better it is for them too, right? Because we don't want them to go over the cliff either before they figure out that they got to figure out a different system, you know?
Thank you. Gowri, did you have any other comments you wanted to make?
No, clearly, our union is in support of single payer because of the nature of the work that we do and the mass of part-time workers that we have. And so, yes, and clearly any contributions you want in terms of phone banking, I think I can put the word out to my own union members and keep pushing them to get more involved because this is unstable and, it's the problem is only going to get worse. I feel there's no way that it's going to get better, so I feel like now is the time to change the system that we do have. So, people can be assured of healthcare. And I totally agree with, I can't remember who it was, maybe Christine, who said that, first we decide on the principle, what's the more model principle here before we start talking about the details. So it's not just about the workers who do have healthcare, but about people with unstable jobs who need it. And so clearly I would be happy to volunteer and yes, thank you so much. I learned a lot. Thank you, John. It was really revealing for me. The questions you asked are, some things that we have to be thinking about here.
Thank you, Gowri.
Thank you, Gowri, and thank you, John. And thank you, everyone. I mean, I think that, we could say that this was a sobering and sort of gloomy perspective, but it's a gloomy perspective in the service of being able to do the same kind of work that we've been doing to pass this bill, which is something that would guarantee healthcare for everybody. And that's just that very primitive idea in healthcare is something that we have been organizing on and talking to people about, because in this country, people have no idea what that means to guarantee healthcare and how that would change everyone's life dramatically. So we still have our very much on the ground work to do. And the fact that there is opposition in some parts of organized labor and opposition in other sectors, it doesn't stop us. So I think it plants our feet on the ground in a slightly different spot, because some of those aspects and facts are new to some of us. And I certainly learned a lot tonight as well, but same feet are still marching on the ground, and we just know it's a long fight, but in the end, it's the only way. Thank you, everybody. Thank you especially for both of our speakers spending so much time. Thank you to NIPAN for everybody coming from all over the state, which is not always the case here, although Ting and I have been talking about including people from other districts in more of the work that we're doing and unifying. And again, I think it's a unique time because of the pandemic and people losing their jobs and people losing their healthcare and people losing their lives. I think that we need to continue to make that moral point and that organizing point. So thank you to everyone. Just an announcement about our next meeting, and we haven't figured out exactly what the agenda of that meeting is, but we know we're getting closer to a time when this bill might be introduced after the budget season. So we're back to our old every first Tuesday of the month meetings. I was the one who was not able to keep doing that because of Physicians for National Health Program having different meetings. So, my apologies for throwing people off our schedule that we've had since 2017, but we're back to the first Tuesday of every month. And we invite everybody to come, and anybody again who has not been on our email list but would like to be, just before we close tonight, put your name in the chat, because we may be doing this kind of meeting, not just our local organizing, although our local organizing has been totally powerful and impressive. And thank you to our local people for doing that over the years. So here we're in it for the long haul, and thank you for the perspective that our guests gave us, and wishing everybody a sane new year and good health, and thank you.
Everybody in, nobody out.
Thank you very much.